Everybody, this is Dr. Perry coming at you from Stop Chasing Pain. I'm really excited because this is my first venture into this Google Plus video broadcast, and it was actually my guest suggestion to do it. So it's going to be kind of a work in progress to get through. Hopefully, you'll like it. I'm pretty excited for it. And the other guy in the other picture over there is a good friend of mine who we actually just met for the first time through the video here, but we corresponded back and forth quite a bit. And hopefully, Urson, I'm going to see if I get this right. Urson religioso, is that right?
That's right, Perry. Thanks.
All right, good. I got it right. And I'm going to let him tell you a little bit about himself, and then we're going to get into some really cool topics about some of the wonderful things he has that he helps people suffering in pain and some wonderful new programs that he's got coming up. So, Urson, tell the viewers a little bit about yourself.
Well, I'm a doctor of physical therapy. I graduated from DeVille College with my bachelor's and master's in '98, and then again from the University of St. Augustine with my doctorate in 2000. After that, I pursued fellowship training in orthopedic manual therapy. So traditionally, very strong joint model with a little bit of tissue work. And then after that, I tried to go to as many different seminars as possible. Throughout that, I ended up teaching for several of the local colleges. About 2 years ago, I started blogging to promote some of my products, because basically once you buy a tool or a product from me, I felt like there was no reason for anyone to come back to the store. So then the blog kind of took off, and I ended up meeting a lot of cool people like Perry and Mike Reinold and Rick Daigle. So as a result of that, now I'll be starting like my first tour all around the U.S., teaching for Medical Minds in Motion, and also in Canada, teaching for Rock Tape Canada, and in South America for TheraAdvance. So my approach is called the Eclectic approach, and it's kind of based upon MDT, or the McKenzie technique, and the SFMA for assessments. And in the treatment, I do a little bit of soft tissue work, a little bit of manipulation, a little bit of aerodynamics, MDT-based home exercise program, correctives, and then if all else fails, then I do a bit of FFMS as well. But I am a novice to that, because I've just been dabbling in that in the last year.
Yeah, well, I mean, you've got an amazing background and combination of things. And what I love about your work is that you're willing to just introduce many things, whatever it takes for the benefit of the patient, which is one of my favorite things. And we want obviously in the same circles with Rock Tape and Medical Minds in Motion. And you got a fantastic blog. I want to make sure you highlight that and tell people at the end where they can get that. It's one of my favorites. And correct me if I'm wrong, but you're getting nominated for some kind of award with that, right? With the blog, it's something that's one of the top blogs out there.
Yeah, like I said, I've only been blogging for about a year and a half, almost 2 years now, and it just kind of exploded. I mean, it was my goal to just be one of the most exposed blogs out there, and thanks to, again, guys like you and Mike Reinhold who shared my stuff, I quickly got out there, and plus I started blogging Monday through Friday. And like, you're so prolific on Facebook. People say, like, do you ever sleep? How do you find the time for this? You just make the time. And maybe some of us are a bit more tech savvy or a bit more wordy than others. But blogging Monday through Friday, it's like 95% free. There is a slight subscription channel for those who want like hours and hours of instructional videos. All the stuff I teach in my courses, it's on there too. But it's themanualtherapist.com. So I blog about clinical courses, about using soft tissue work, different clinical decision making. I try to have about 2 or 3 cases a month, and I also have a forum on there that I try to keep pretty open and troll free if possible.
Yeah. Well, what's the blog address? I know once I get my tech savvy down with this media, I'll kind of I'll post it up there with a link. I want you to tell everybody now who's watching in case they want to go to that on the side.
Yeah, it's themanualtherapist.com, all one word.
Nice that you got that domain name.
I know. I was pretty lucky, actually, that no one thought of that.
Well, I want to get into a couple of things, and hopefully you actually have your tool with you.
I do.
You sent
Yeah.
me the Edge tool, which is awesome for soft tissue work. For people that are watching that may not be familiar with instrument-assisted soft tissue work or the basic premise behind it, can you cover that and what gave you the kind of direction to create your own?
One of the programs I graduated from, Paris's program where I got my doctorate, they recommended that you do tissue work first, then joint work, then neuromuscular re-ed in that order, because you're going to make a lot of changes with tissue work, and you may not even need to do joint work. So the more I got into tissue work, and after taking a couple courses from the Institute of Physical Art, I started doing a bit more functional release, which is very similar to ART. I noticed that I was doing much less manipulation and much less joint work. Because there was more of a carryover between visits and more patients could tolerate it. There was less contraindications. So about maybe 10 years ago, I was treating the son of one of the faculty members of a local chiro college. And he saw that we were using our hands a lot, and he saw that we were doing a lot of manipulation. So he brought in his Graston tools, and he had us demo them. And I thought, oh, these are pretty cool. How much are these things? And right, yeah. So they're, at the time, especially with me being a pretty new clinician, they're out of my price range. They still may be out of my price range. I just kind of refuse to pay for them. So I thought that someone could make similar tools, and there are definitely a lot of other tools out there. So again, I try to differentiate myself by making not only a stainless steel tool. You can purchase it for a low price. I just charge $110, but I wanted to back it up with courses. I wanted to back it up and change the models out there as well. Unlike the Graston model, I don't teach fascial deformation because that's pretty much been disproven in the research. The research by Schleif and others, they basically show that you need like hundreds of pounds of force to deform an IT band, even 1%. So I don't think I work out a lot, but I don't think I'm superhumanly strong. So I started using less and less force over the past 2 years, and to my surprise, there was actually, I still made large changes and global changes. And when I started to look at models like that and the tensegrity model, I knew that what others were calling lines, and what I call, and I kind of discovered on my own patterns because I was never exposed to like an anatomy trains model before. That you can make global changes and big changes. So. The other thing I found about using tools, and I'm going to get into this because I posted on some of the research on Monday, and get into some of the advantages tomorrow in a blog post, is that other than the obvious use of saving your hands, there's something I noticed, because basically all we're doing is tone reduction to enhance movement. We're not deforming fascia. So there were certain muscles that are definitely more tonic than others, for whatever reason, poor movement patterns and poor postures, things like that. So whether you say if it's your masseter or your upper trap and you're releasing them, I found that there's something about this functional tone actually responds incorrectly to another person's touch. So I work on about 50% of my caseload is actually TMD and headaches. So I was doing a lot of masseter release, and back when I was using a bit more force with my tool, I never wanted to bruise anyone's face, because it's been well over a year since I actually caused any kind of permanent discoloration, or not permanent, but discoloration the next day or two. So one woman, I wasn't getting anywhere with the release, and I was using reciprocal inhibition as well. And so instead of just using my 2 fingers, she said, "Why don't you use that tool of yours that you use on my neck and my mid-back?" So I started stroking the masseter, and to my surprise, the tone actually reduced quite a bit faster. And I started experimenting it over the past year during some of my courses. There's some people who had, the typical kind of big trigger, whatever you want to call it, Oshii point here. And in one of my courses last October, one woman's like, "Oh, feel this, no one can release it." So I was palpating back and forth, and there was a pretty big nodule there. Again, whatever that nodule is, these things don't exist in dead people. They're only palpated in the living. So we know that, again, whatever we're feeling it's a dysfunctional response of tone to another person's touch. So when I was snapping back and forth with my hand, and then I just grabbed an edge tool and I started trying to do the same thing, I was able to actually push quite a bit deeper, and the nodule was still there, but it was definitely smaller. So other than the obvious hand saver, I think that when someone really has dysfunctional tone and you're not able to release it with your hands, you can try any inanimate object, because part of that tone is it's a abnormal response to another person's touch. Because we can facilitate tone, but you don't want to facilitate tone where there's already high tone.
Right. Well,
That's another advantage to using tools.
yeah. Can you hold the tool up and show a little bit about the design of it and why you made it that way?
Well, they're similar tools again on the market, and this has actually already been copied. It's another reason why I started blogging because Mike Reinhold featured a copy of the tool that a student of mine stole the design and brought it to market first. So that's another reason why I started getting into social media. But I wanted there to be a handle because I used Graston tools. Several of the fellows that I trained in manual therapy fellowship, they were Graston certified. They let me use their tools, but they are hard to hold, like the butter knife. The ones that you use more common, they're hard to hold for a long period of time. So I wanted to include a handle, and then the handle I think is a mostly one size fits all. Basically, Gray Cook in his big man hand said that the handle was too small, and he wanted me to make like a separate handle just for him. But it is kind of expensive to make a one-off handle for his huge Superman hands. But you don't always have to hold it like this. But I think one, if you think that the handle is too small, you don't have to use all your fingers. But there's a lot of different sides to it. The least aggressive side, what I call side one, is the largest concavity. That basically fits larger parts like arms or thighs. Second most aggressive is the largest convexity, and then there's a side three and side four. So this would be side two. Side three and side four are just progressively smaller convexities because basically force is inversely proportional to the amount of surface area you put it through. So the less surface area, the more force you can potentially apply. So I made the smallest one to kind of accommodate like the Graston tool, the people who wanted a small hook-like protuberance to kind of go between MCPs or to kind of go underneath scapular or bony contours. So this is small enough for that. It's not quite the hook, but I find you didn't need that. And then in some of my earlier iterations, it wasn't quite as sharp, and I found some people think that it's too sharp, but I did look at the Graston patents, and I purposely made the sharper edge. So logo side up, when you're holding it at an angle, it's a bit sharper, and that's for very, very just superficial scanning. But again, I don't really use too much more force than this because all we're really doing is just moving skin on the superficial layer of fascia. We're not really changing anything deep other than possibly just the first layer. And even those changes probably are only transient in nature. A couple hours later, unless the patient maintains their correctives, they're not really going to hold up. But if you do need to progress your force, all you got to do is flip it over, and there's a flatter end. So on any of the other sides, you can just flip it over and be a bit more aggressive. Probably about 95% of the time, I actually use the flat end. I very rarely use the very superficial side. But again, I use this on anyone from 6-year-olds to 9-year-old little old ladies because there's just less contraindications to tissue work than there are to joint work. You can use it on someone who's unstable and just promote recruitment and again, if someone's unstable, you're not going to do joint work. So I think everyone needs a little bit of manual before they get into their movement and correctives. So this is just something that I use on almost everyone. And my hands feel a heck of a lot better because even by the time I was in my late 20s, and that was a while ago, my hands were already hurting. So
Yeah, you got to look long term for the health of yourself and the
yeah,
durability of what you love to do. And you sent me the Edge a while ago, and I use it quite a bit, and I love it. And I actually had it done on me. There's much more fun on the other side of it when you're giving it to
yeah,
somebody.
right.
Rick Daigle actually did it for me when my ankle was really jacked up. He did it on my peroneals, and then he did some needling. Oh man, it was just a wonderful combination. And
Thanks.
he put that in there with some of the rock sauce for Glide, which is the analgesic that Rock Tape used, rock sauce. And I was curious of how you integrate your soft tissue work um, prior to movement and how you do taping with it, because I know you're a big fan of the fashion movement tape and stuff with Rock Tape like I am, and how you
Well,
kind of meld those two together for a nice response from patients.
right. Well, I've been like dabbling in taping over the past year with no formal training. So thanks to Steve Capobianco, he invited me up to Rock Tape Canada's inaugural first course which is really just like an hour drive from me because I'm in Buffalo, New York. So I really like their theories, and they're pretty modern, and they're really just taping movement and not specific lines or insertion, origin to insertion, or any of the more mechanical methods of formal kinesiotaping. So in my courses, again, I've never exposed to what others have done in the past. I just kind of developed them parallel with that. I tend to teach to work on patterns. Like, you're going to work on the temporalis, proximal to distal, the maxillar, proximal to distal, more the cervical paraspinals, proximal to distal, the scalenes, and the traps medial to lateral, or lateral to medial, whichever way you experience more resistance. So after you do anything like this, again, because like the research by guys like Schleip and others basically show that even if we do make changes in that first layer of skin on fascia or skin on muscle, that those changes are not going to last for more than a few hours. So other than giving people correctives and MDT-based repeated motion, usually in the direction of limitation, I tend to tape them. So because research that rock tape showed when they did some the extension with and without the tape, there was like that subtle slight lifting effect. I think it's a really good way to lock in any improvements you make. So if someone was actually limited in side bending to the right, I find you actually make more changes by working on the ipsilateral side rather than the contralateral side, because people tend to think, oh, you got to work on the opposite upper trap to improve side bending to the right. But sometimes it's more of an issue of tissue folding and joint closing, and I find I make a bit more changes with that. So then you can lock in those same improvements by taping them afterward.
That's great. And, what role? I know you do a lot with corrective exercises, and you have a program with that as well. How do you incorporate that into your program with your clients, and is that a big part of your overall therapy program?
Right.
I'm really fascinated to see how your patterning goes. The word you use I like a lot, from your soft tissue work down into more active-based movements.
Right. So my client caseload is pretty much like 50% TMD. Then I have about another 30% are runners or athletic, more minded people. And then just the rest of their just kind of general ortho and spine. So regardless of whether they're an athlete or they're not an athlete, one of my prime methods of assessment, other than the SFMA, is MDT, or the McKenzie method. So I find there's not a lot of exposure in like the sports and fitness worlds to that approach, almost because it's too simple. Again, I've only been dabbling in like the FMS's 4x4. Mainly because I haven't finished the courses, and two, MDT works so well for me, and it's so simple that whether you're an athlete or someone who doesn't move well, they can still do the corrective self-resets. So I've been finding, and the McKenzie Institute would agree with this as well, that again, like I said, if the average person, they're probably not going to be able to help themselves, whether they have neck pain. Let's just use, like, again, if someone's had unilateral right-sided neck pain. So if the right side of my neck hurt, most people are going to say like, oh, I really need to stretch that. But according to the McKenzie principle, most joints or areas are going to have what's called a directional preference. So the directional preference is one direction, and only one direction, that is going to actually, whether it's a sustained position or repeated loading in that direction, that's actually going to improve the motion, reduce pain. If they have radiating arm pain, moving in that direction, maybe between 8 and 9 times out of 10 is actually going to bring the arm pain or centralize it back up to the neck, and their motion is going to rapidly improve. So with just very simple repeated end range loading, you actually, patients able to manage it on their own. So where I use tissue work and sometimes manipulation is that if a patient is unwilling to push into it, because often it hurts, and it may feel better to stretch the right upper trap, but that direction is contrary to the direction that's normally going to make them better. So if you get them to repeatedly load into that one direction, I use my tissue work and again, sometimes manipulation if I have to get them to be able to load into that repeatedly. Because basically, again, research shows if you're doing a manipulation, The temporal effects of that are between 5 and 45 minutes for any kind of neurophysiologic reset you may get, and only 24 hours for pain. So one of the big tenets that the McKenzie Institute teaches and I teach is you got to do these repeated loading exercises 10 times an hour. So it used to only work for the spine, but then they started teaching for the extremities as well. And many of these resets are so simple that anyone can do them. And so after I teach a tissue course or a manipulation course, I always teach very, very simple resets. Another great example is the ankle. Most people you're going to be limited in dorsiflexion over plantar flexion, but everyone keeps on stretching into dorsiflexion. So the best way to get the neurophysiologic reset and activate the most amount of mechanoreceptors is to get to end range. So if you're limited in dorsiflexion, but you can't get to end range, you're not going to be able to rapidly change it. So instead, you could actually just do like repeated end range loading into plantar flexion. And it's just something that no one ever does because you think that you have to keep on stretching into the direction of limitation. But because you get to end range, you can get to end range in that direction, you activate more mechanoreceptors and it works better as a neurophysiologic reset. And it's something that I'll do, like I'll have, on an SFMA, I'll have limited tibial IR, I'll have limited dorsiflexion, I'll have limited hip extension. So before every run, I'll just do 10 to 20 repeated end range loading plantar flexions. I'll do some tibial IR, mobilization with movements, and I'll actually do repeated hip flexion to improve my extension. And those are all things that make rapid changes. So, if we can make rapid changes in someone that they don't really have true tissue extensibility issues, and I think that McKenzie research, what they call derangement syndrome, most people about anywhere between 80 and 90% actually fall into like a rapid responder category versus people who respond slowly and actually need a lot of work.
That's absolutely fascinating. It makes perfect sense, but it goes against what everybody inherently wants to do, but more frightening, it goes against what most people do in the healthcare field.
Yeah, it's almost too simple. Like 10 years ago, people were like, "What do you think about McKenzie?" I'm like, "That's too easy." I was even certified in it, and I didn't like it because I was like, right. It's just too easy. But what goes around comes around, and I make that a basis of my approach. So, so that along with the SFMA, that's how I teach assessment because both of them are very systematic methods to find dysfunction. And the big thing with MDT is that the patient will have a very, very simple home exercise program, often one or two things that they can use to manage.
Well, that's what I love about it, the simplicity of it, because I think in our world, people tend to overcomplicate everything, and most people in the real world, when you give them 20 exercises, they're probably going to be zero. So if you can give them one or two that makes them feel more confident, feel better. But the one thing I like about what you said is that you're actually helping these people become comfortable and feel safer getting into movement that normally they would be afraid of.
Right. Yeah, I mean, I follow all the pain science. I follow a bit of the pain science approach as well. I don't get into it too much with clients because the neurology behind it gets over their head. But yeah, one of my first goals is to decrease that perceived threat because many people are on the verge of either central sensitization, but yet they don't move well and they're definitely afraid to move. So that's where all my manual comes in. I mean, manual therapy. The best trainers can get someone to move well, and they can do the same things. But manual therapy, even like Gray told me, it's a shortcut. It just makes it easier for us to do. We can get there a bit faster because we can use our hands to make movement feel better. So you make movement feel better. They're less afraid to move. They're less apprehensive. Then for me, they can get to end range, and as long as they can get to end range, you're going to see much more rapid changes.
That exactly, and I can say, hold on, my phone's ringing. This is real life, man. I'm gonna turn my phone off.
Technical difficulties.
Also, a lot of people when they hear McKenzie, when they're in our world, they only think low back.
Right.
So, but there's a lot more to it than just low back.
Yeah, there is. I mean, it was started by an accident. It was just again one of those things. 30 or 40 years ago, whenever it was, he basically was manipulating someone for chronic low back pain. They had leg pain. He calls him Mr. Smith. And this guy was maybe early, or Mackenzie was busy. And he had a table that was actually propped up like this, and he forgot to set it down. He said, "I'll get right to you once you lie down on the table," fully expecting him to lie on his back. And he actually forgot about the guy. He comes back, and he's kind of mortified to see that the guy was lying on his stomach the whole time. So he was actually extended by like a whatever 50-degree angle for about 20 minutes or so. And then when he gets off the table, Mackenzie's really apologetic. He's ready to apologize, and the guy's like, shakes his hand. "I don't know what you did. My leg feels so much better." And that was the beginning of his thought process. It was just, again, one of those things that, my back hurts, like, or posteriorly. So everyone always just flexes and flexes and flexes, but the average person flexes 1,000 to 3,000 times a day. And it's like one of my favorite things to tell patients: if flexion was going to make you better, it would have made you better by now. Again, it's often like it's the direction contrary. Same thing with the neck. The back of your neck hurts. Well, it's like, oh, I got to keep on stretching it and stretching it. It's like, if it was going to make you better, I mean, so there are some cases where flexion makes people better, and that's another fallacy, or misconception of the Mackenzie approach, is that it's all extension. It's not all extension. Sometimes it's bending to the side. It's usually just a direction contrary to what someone is doing.
Mm-hmm. Yeah, I love that. It's just a thought process of looking outside the box sort of thing. But your whole treatment model falls into stuff that I've quoted all the time, is saying that more is not better, better is better. Like,
right, yeah, better is better. Yeah, definitely.
Stuff, if you can do simple changes that makes an effect on people. But it takes a lot from a clinician, in my opinion, because you really got to own what you're doing. I think people just do a blanket approach and hope something sticks, as opposed to doing something and really saying, "Hey, am I doing a good job?"
Right. Yeah.
Just curious as to, I'm going to kind of get back to one other question I was going to ask before about joint manipulation. But what made you get into the TMJ part of it for you? Is that you enjoy it, or because I know it's a huge market of people that suffer so much and there's so little help for it?
Well, I happened to study under one of the only physios in the world. His name's Dr. Mario Narakabato. He proved a long time ago, probably in the 70s or 80s at some point, that the jaw position is related to the head and neck position. He developed an approach based on that. So he's a physio in Chile. He's one of the only physios in the world who actually works in a dental school. So he's a very prestigious guy. He brought our profession into treating the TMJ. So I took all of his courses. I became certified in his approach, and that approach actually made me better at treating the cervical spine and headaches in general. So I ended up just marketing to the right guy. It's the only doctor that I ever marketed to that it ever worked. Because you always market to people, and there's like, who's this bozo walking in? So I happened to go to school with his daughter, and that was it. And then he started sending me patients, and I started getting them better. And he sees like 90% of the TMD clients in Buffalo, New York. So indirectly, lawyers, whoever, they all refer to this dude. So I started seeing a lot of his patients, and then someone took over his practice a couple years ago, right when I started my own private practice. And I was pretty worried about that, but he refers me a lot of patients too. So, virtue of being one of the only certified clinicians in this approach, there's probably only a handful of us in the nation. I'm also one of the only guys who does it in town, because not everyone wants to stick their hand in someone's mouth. Whether you're a chiro or a PT, it's not the most glamorous things. I probably get bit about once a week due to the high tone of the masseter, but it's a joint like anything else, and it responds very well to postural correction, soft tissue work, and MDT. So I think every TMJ patient's like 90% cervical and 10% TMJ, and very few aren't going to respond rapidly like most other patients. So that's how I got into that. I took the right series of courses, I marketed to the right guy, and I only had to market once.
Yeah, and plus you're dealing with a condition that's very difficult, and most people, and you probably tend to agree with me, my whole motto is stop chasing pain. I mean, they probably just zero in right on this guy right here, and
right.
any place else down, your program does.
Right, yeah, they're like, why are you working on my mid back or something like that? But people let you do anything as long as you can explain it and explain why it's important and show 'em how it makes them better. So yeah, that's how I got into that.
Yeah. Well, I wanted to ask you one more question before we kind of move into wrapping it up. I know we got a late start, and you got things to do, and then I want to talk about your workshops and how people can get more information from you. But as a chiropractor, my background in that, which I don't really do too much. I mean, my how I got to a point of looking more at movement and correctives was because I was very frustrated of why I would do a manipulation and it would feel good for like a day, and then they come back and I have to keep doing it over and over and over, but it never really truly set. And then my whole paradigm shifted when I just wanted to ask, well, what the hell is that? Is it frustrating? Um, so can you get into a little bit again? You kind of touched on it of how um, joint manipulation, although an effective tool, that if you do some of these other things that you discussed, it can take a person from point A to point B much faster or help keep them at point.
Right. I mean, classically trained as a manual therapist, I did a ton of manipulation. I was manipulating everyone, and one of the reasons when I teach manipulation, one of my indications why you should do it is because it's awesome. Everyone likes it. It's like if you're good at it, you like it just as much as the patient likes it. And no matter what, we have research that shows the pop isn't needed. And yeah, you may have the same outcomes like after 8 weeks if you don't get regular cavitations, but everyone agrees that whatever happens, even if it's just all mental, that there is a much better release once you actually get that. The thing is, though, again, the more I did tissue work and the more I did McKenzie approach and just repeated end range loading. Again, 10 years ago, I never would have believed that literally only 10% of what McKenzie says, or less than 20% actually need hands-on. If you're really, really good at getting a patient to move the end range, you can get them to maybe push through all that discomfort. You will make big changes. But where I use tissue work and rock tape, I get them so that the movement is more comfortable, so they can get to end range faster. And I think that I've trained a lot of McKenzie diplomats, and they're basically the highest trained McKenzie practitioners in the world, and they can definitely get a patient to move to end range. But I just don't want to maybe spend 45 minutes with a person just working on one motion hundreds of times and have it finally get more comfortable. Because if I can, I do about half hour per patient. So if I can spend 10-15 minutes doing tissue work on various patterns, a little bit above, a little bit below, according to what the SFMA tells me, get their movement to be more comfortable so they can do it at home, then I know they're going to be more compliant and they're going to come back with better and faster outcomes. It works really well when someone doesn't want to be touched, but when someone wants to be touched, I mean, there was a recent piece of research that showed last year, is one of my favorite pieces of research, our cervical thrust manipulation clinical prediction rule. One of the major factors, there's 4 factors, other than tenderness in the mid neck, it being acute and having limitations in neck range of motion. One of the major factors was the patient's positive expectation of it. It's like if someone wants it and they're hell bent on getting it, if they're going to go running off to a different clinician, if I don't do a thrust, I'll probably do a thrust just because they want it. But I still got to tell them that, if you want to come to me forever, you're going to only get that. But if you really want to get better and you want to stay better, you got to do other things. You got to make changes. You got to, it's like the definition of insanity. You keep on doing the same thing over and over again, expect something different. If you want to change, you're going to have to make changes. So as long as they want to change and they have that in them to change, then I think thrust or manipulation is just another tool to get someone to move better. But it's not going to make any permanent changes.
Perfect. Great. Well said. Well said. Well, why don't you tell everybody how they can get some more information about your courses and your website. I know you and I are going to be teaching soon for Medical Minds in Motion going across the country.
Yes,
talk about that course as well. Guys should definitely check out the Medical Minds in Motion and Rick Davis' work. It's awesome stuff. And let them know how they can learn more about what you do.
Right, like I said earlier, we'll put up the links. So the manualtherapist.com is my main blog. I also have edgemobilitysystem.com. It's all one word, edgemobilitysystem.com. All those links are on my main page. Got a couple Facebook pages. All that stuff can be found on my main blog. So like Perry said, I will be teaching through Medical Minds in Motion, medicalmindsinmotion.com. You can search per state. Also on my name, I have my course calendar. So I can't just say that, but it's ERS as in Sam, ON as in Nancy, RELIGIO, S as in Sam, O.com. I have the course calendar. Or you can just go to themanualtherapist.com and click on the About section about me. That'll take you to my main page, other than my blog, which has like my course calendar on it. So right now I'm scheduled to teach in Boston in a couple weeks, then Chicago in April, and then Texas in April. Waiting on New York credentialing. I'm going to go to Illinois and Pennsylvania later in the year, and then Chile in June, and then starting up something with Rock Tape Canada later in the year. So hope to see you guys there. So you can tell me you watched this, or tell me you're an SCP fan or an OMPT fan on Facebook. That would be great.
Yeah, absolutely. Make sure you guys go support and represent. I just know one thing, man. I got to catch up to you. You're already going global.
Great.
I got
Hey, you're invited down to South America too, right?
Yeah, I'm probably going to be doing a lot of traveling coming up as well. It's amazing how people all over the world have gravitated towards the Facebook page that I have, and also towards your work. And I'm sure you'll agree that it's just so much fun to help share your ideas and open people up to some new things, but also continually learn from them too.
Right. Yeah, I do learn a lot. I learn a lot from you every day, and I always think, I think about you, what everyone thinks about me. Like, where the hell does he get the time to do this stuff? So part two of the interview is actually going to be me interviewing Perry. So we're going to plan that hopefully sometime in the future. So thanks for joining, guys. Sorry for the technical difficulties. We had a late start.
Yeah, that's my fault. It's like, hey, I can fix a human being, no problem. But getting this
Right,
stuff
yeah.
done, a little work.
You need to laser your Mac.
I'm gonna laser this computer, man.
Yeah.
Got to get it going, and I promise everybody I'll post up some links and stuff like that. Everybody will be able to easily get to Harrison and his work. So, my man, thank you so much for coming on. It was great to actually finally talk to you, and it's going to be an honor for me to work with you more in the future.
Yeah, I'm excited, Perry. Thanks.
You got it, man. You take care.
All right, we'll see you.